Welcome back to the podcast. I am Dr. Khan, and I am pumped to dive into some cardiovascular basics today. We are talking about the plumbing of the human body, specifically why some blockages are just a minor detour while others are a total catastrophe. Joining me is the ever-precise Dr. Sarah.
Glad to be here, Dr. Khan. Today we are focusing on blood vessels, specifically the distinction between anatomic and functional end arteries. For those of you prepping for your board exams, this is high-yield territory. Understanding why certain tissues undergo necrosis while others survive ischemia is a favorite topic for examiners.
Perfect. Let's start with a real-world scenario. Imagine a 65-year-old man in the ER. He's got crushing chest pain that radiates down his left arm and into his jaw. He tells us he's had this before while gardening, but it usually goes away with rest. This time, he was just sitting in his chair, and the pain won't stop. Dr. Sarah, why does the sitting in the chair part change the game?
That is a classic clinical presentation of the progression from angina to a myocardial infarction. In angina, the coronary arteries are narrowed, meaning blood flow is sufficient at rest, but insufficient during exertion. However, when the pain occurs spontaneously and persists, it indicates a sudden reduction or complete stop in flow. In medical terms, we are moving from ischemia, which is stress tissue, to infarction, which is actual tissue death or necrosis.
And that brings us to the why of today. End arteries. I like to think of blood vessels like a highway system. Most of the time, if there's a wreck on the main interstate, you can take a series of back roads, what we call an anastomosis, to get to your destination. But what happens if there are no back roads?
That is exactly what an anatomic end artery is. By definition, these are vessels whose terminal branches do not communicate with branches of adjacent arteries. They are the sole source of blood to a specific target area. If you block an anatomic end artery, the tissue it supplies has zero backup. It dies, period.
It's like a dead-end street with no side alleys. The retina is a classic example. If the central artery of the retina gets blocked, that's it. Vision is gone because there's no detour. But Dr. Sarah, the heart is a bit more complicated, isn't it? We talk about functional end arteries there.
Precisely. This is a subtle but vital distinction for the boards. Functional end arteries actually do have anastomoses with neighboring vessels. On paper, there is a backroad. However, the caliber or the diameter of these connections is so small that they can't carry enough volume to keep the tissue alive if the main artery is suddenly occluded. It's like having a tiny walking path as your only detour for a 6-lane highway.
I love that. So in our 65-year-old patient, his coronary arteries are functional end arteries. He might have some tiny connections between vessels, but when that main coronary branch shuts down, those tiny paths are like trying to put out a house fire with a squirt gun. It's just not enough. Why does this matter clinically? Because it dictates our window for intervention.
Exactly. And students should note that while the body tries to create collateral circulation over time, essentially widening those back roads if the narrowing happens slowly, a sudden blockage doesn't give the body time to adapt. On a board exam, if they ask about the consequence of occluding a functional end artery, the answer is still ischemic necrosis or infarction, despite the presence of those ineffective anastomoses.
You know, as the doctor of choice for my students when they need a clinical analogy, I always tell them to look at the joints. Dr. Sarah, the book mentions that arteries crossing joints usually have great anastomoses. Why is that?
That is a great point. When you flex your elbow or knee, you actually kink the main artery, much like a garden hose. If that were an end artery, your forearm would go ischemic every time you picked up a phone. Instead, we have a network of vessels around joints that ensure blood flow continues through alternative channels. That is functional anatomy at its best. So to recap for the listeners, arteries are the delivery trucks. Most of the time, they have overlapping routes, anastomoses, to make sure the goods get delivered even if one road is closed. But in end arteries, the route is unique. To be very precise for your notes, anatomic end arteries have no connections. Functional end arteries have connections, but they are too small to be functionally useful during an acute blockage. Both lead to necrosis if occluded. This is why the coronary arteries of our 65-year-old patient are so critical. They are the definition of functional end arteries, and his hard muscle is paying the price for that lack of a viable detour.
Man, it really puts the pressure on us in the ER to open those vessels up fast. Time is muscle. Dr. Sarah, what is the one high-yield takeaway for someone walking into an exam tomorrow?
The takeaway is this. The presence of an anastomosis does not guarantee tissue survival. If the anastomosis is functional only, like in the heart, sudden occlusion will still lead to infarction. Always distinguish between the anatomic presence of a vessel and its functional capacity.
Brilliant.
Thanks for the clarity, Dr. Sarah. And to our listeners, remember, in the world of anatomy, always ask yourself if there's a backup plan for the blood flow. If there isn't, you're looking at a potential clinical emergency. See you in the next episode.